In neurology, you rarely find a single tool built for opposite extremes. On one end, violent, chaotic electrical storms rip through the brain's cortex. On the other, a subtle, rhythmic mechanical flutter in the hands. Yet the exact same medication is prescribed to manage both. It's an anticonvulsant in the deoxybarbiturate class known as Primidone. For decades, physicians have relied on it to suppress severe seizure disorders. It targets generalized tonic-clonic seizures, as well as complex partial and partial seizures. But look at a different patient's chart and you'll see it prescribed for essential tremor, specifically to steady the involuntary shaking of the hands. This raises a specific question. How does a single parent molecule address two drastically different neurological pathologies, requiring completely different dosing protocols? The liver dictates Primidone's clinical behavior and toxicity by transforming the parent drug into entirely different chemical compounds. To understand this medication, we must bypass the brain initially and look straight at the liver. This is the critical site of first-pass metabolism. Immediately upon entering the hepatic system, the parent Primidone molecule is dismantled. It splits into two distinct active metabolites, phenobarbital and PEMA. Both chemical byproducts are pharmacologically active, but phenobarbital does the heavy lifting. This is the primary driver of the drug's potent neurological effects. We can now follow that phenobarbital out of the liver, into the bloodstream, and across the blood-brain barrier, down to the microscopic neuronal level. Here, phenobarbital locks directly into the GABA-A receptor sites on the postsynaptic neurons. This specific binding action opens chloride ion channels, allowing negative ions to flood the cell. It enhances the brain's natural inhibitory signals, essentially applying a chemical brake to the entire neuron. By forcing this decrease in neuronal excitability, the drug systemically suppresses the abnormal, hyperactive electrical bursts that trigger seizures. And it is this exact same generalized suppression of the central nervous system that dampens the overactive signals responsible for essential tremors. Achieving clinical control isn't about maintaining high levels of circulating Primidone. Success depends entirely on sustaining a steady state of its phenobarbital metabolite in the brain. This reliance on a metabolite creates a highly specific internal clock for the drug, dictated by plasma half-life. This graph charts the primary half-life of the parent drug. Primidone clears the system in a relatively brief window, roughly 10 to 15 hours. But here we hit a clinical paradox. If the primary drug clears in under a day, why do the therapeutic effects and the severe drug interactions persist for many days after a single dose? We have to look back at the active metabolite. Phenobarbital operates on a vastly extended metabolic timeline, lingering in the plasma for several days. To evaluate a patient's true pharmacological state, you must combine that initial spike with the trailing metabolite curve. Because of this long trailing curve, a stable neurological response does not happen overnight. It takes significant time for active levels to build up and plateau in the patient's system. Expecting immediate, complete seizure or tremor control after taking a single dose is a dangerous misconception. Failing to account for this dual timeline is a major clinical pitfall. If a physician sees no immediate improvement and prematurely increases the dosage, that trailing accumulation of phenobarbital will rapidly push the patient into severe toxicity. That toxicity risk directly shapes real-world dosing strategies. For adult epilepsy, achieving seizure control demands a heavy maintenance dose, typically between 750 to 1,500 milligrams per day, divided into multiple doses. This chart shows that aggressive dosage requirement compared directly against essential tremor management, which requires a significantly lower target dose to steady the hands. Clinicians manage both indications by starting at a minimal dose and gradually titrating upwards. This slow titration schedule is absolutely mandatory. It is the only way to mitigate the harsh initial shock to the central nervous system as the GABA-A receptors adapt to the inhibition. Even with careful tapering, patients commonly experience severe early side effects, extreme drowsiness, dizziness, nausea, and ataxia, a noticeable loss of physical coordination and balance. Far rarer but critical to monitor are severe adverse effects that demand immediate medical evaluation. These include severe CNS depression, severe allergic skin reactions, and sudden suicidal behavioral changes. When treating children, the rules tighten further. Pediatric doses are strictly individualized based on weight, age, and seizure type. They are never a simple scaled-down copy of an adult prescription. Ultimately, aggressive early side effects like ataxia and fatigue serve as direct, unavoidable proof that the GABA-A inhibition is working systemically. Careful, slow titration is the only safe path to navigating those effects to achieve seizure control. While the brain adapts to the drug, a secondary, hidden consequence is quietly accelerating back in the liver. This is known as CYP enzyme induction, and it is a major pharmacological danger triggered by the phenobarbital metabolite. As phenobarbital circulates, it forces the liver to massively overproduce its standard drug metabolizing enzymes. By turning the liver into a hyperactive metabolic engine, other critical medications in the patient's system are broken down and cleared far too quickly. For patients relying on hormonal contraceptives, this accelerated metabolism can clear the hormones before they take effect, rendering birth control entirely ineffective. The risk applies to anticoagulants as well. Clearing blood thinners out of the plasma too rapidly drastically increases the patient's risk of dangerous clotting. This compounding danger extends beyond prescriptions to lifestyle habits, specifically the strict warning against consuming alcohol while taking Primidone. Alcohol creates a synergistic CNS depression. It multiplies the drug's inherent drowsiness and dizziness, severely impairing the motor coordination required to drive or operate machinery. Safety requires a comprehensive review of a patient's medication history to account for how this hepatic hypermetabolism alters the effectiveness of concurrent therapies. We finally arrive at the single most dangerous scenario in Primidone therapy, its abrupt discontinuation. Removing that chemical beam of GABA-A inhibition without warning triggers a massive, unsuppressed electrical rebound in the brain. This sparks the ultimate clinical danger, status epilepticus, a potentially fatal state of continuous, unbroken seizures. Because of this severe rebound risk, any dose tapering must be strictly and gradually supervised by a physician. A patient can never stop taking the medication on their own. This absolute rule complicates therapy in special populations, particularly for pregnant patients. While Primidone carries documented fetal risks, uncontrolled maternal seizures are equally, if not more, dangerous to the developing fetus. The drug cannot simply be stopped upon discovering a pregnancy. It requires a carefully managed neurological strategy. Let's consolidate the core pharmacological logic. Primidone is a deoxybarbiturate prodrug. It converts into the active metabolite phenobarbital. It functions via a GABA-A inhibitory mechanism, and it causes major CYP enzyme induction. The clinical logic of Primidone rests on a powerful pharmacokinetic chain reaction, starting in the liver and dictating the behavior of the central nervous system.